So I've been asked to present probably a relatively delicate topic at the moment, so please bear with me. That is about introducing the new treatment into standard of care. My disclosure has not changed since yesterday. So we all know in the DMD community that we had several drugs that failed to show a clinical benefit over the last few years, and has always been very disappointing. But 2025, or December 2024, has been a quite important moment for DMD, because we have the first two drugs that have been approved for the treatment of children and adults with DMD. And these are Vamorolone and Givinostat. Vamorolone received the approval from the MHRA in 2024, and in December 2024, or 16th of January 2025, received the final approval from NICE. And Givinostat received the MHRA approval in December last year and is currently going through the NICE process. So I will start talking about Vamorolone. First of all, what is Vamorolone? And I think this is, for me, is the most important message. Vamorolone is a steroid. For a long time, we talk about steroid as what we were hoping to be the magic pill. The pill that has all the benefit of corticosteroid, but none of the side effects. And I heard a lot of patients talking about is not a corticosteroid, is something alternative to corticosteroid. And I think that it's important to remember that from a chemical point of view, for how the molecule is a corticosteroid. But was designed with the aim to retain the beneficial effect of classic corticosteroid like prednisone and deflazacort, but hopefully minimize the side effects, or at least some of the side effects. I don't want to spend too much time about showing what Vamorolone does in DMD, and the reason of this is because I hope that all of you are aware that we have recently released the summary of evidence with Vamorolone in Duchenne muscular dystrophy, and we also had a webinar for family and patient about Vamorolone, where we present what we know so far about Vamorolone. So I invite everyone who has not looked at it yet. These are available on the DMD Care UK website, both the registration, the recording of the webinar and the leaflet. So here I present a very, 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 very brief summary, so has some limitation. First of all, Vamorolone has been so far tested only in clinical trials. And this is a limitation because we have clinical data about Vamorolone only over a small group of patients, restricted age group, and to a maximum of an exposure, so a treatment period up to 30 months. So what we know is that Vamorolone seems to have a similar effect to corticosteroid on muscle strength and function, and this has been tested against daily prednisone up to 6 months, and then against what we saw is a control group, so historical data of boys treated with either deflazacort or prednisone daily intermittent up to 30 months. So it's a similar efficacy. It doesn't mean that it's exactly the same, but for what we know so far, shows similar efficacy. In terms of safety, I'll just put this. What do we know? That daily Vamorolone, and I emphasize daily because we have always used Vamorolone daily, show that it doesn't seem to have the same negative effect on growth that we see with prednisone and deflazacort. However, it shows similar effect on weight and increase on BMI or body mass index. The advantage, another advantage, it seems to have less impact on the bone health, which result in a lower risk of vertebral fracture compared to daily treatment, but a higher risk compared to boys who do not receive corticosteroid at all or receive intermittent prednisone. And also seems to be associated with less or fewer behavioral issues, but these are really early evidence that need to be further investigated. But similarly, and I cannot emphasize this enough, to prednisone and deflazacort, Vamorolone still cause adrenal suppression. And I emphasize this because it's very important in terms of the management, in terms of the potential risk to have adrenal crisis, but also have some implication if we think about switching from traditional corticosteroid to Vamorolone. And again, on this regard, is something that has been discussed during the webinar, so I encourage everyone to look at the webinar. And Jared Wong and the Endocrine Working Group as part of the DMD Care UK has recently produced some guidelines about how do we switch from classic corticosteroid to vamorolone, what do we need to take into account. So there is no patient leaflet yet on this, but will be ready soon. So based on these evidences, NICE in January 2025, NICE has approved vamorolone for the treatment of Duchenne muscular dystrophy. And this is the final recommendation. What does it mean? Once a NICE approved a drug, each clinical site has up to 90 days to implement the treatment into clinical practice. Because the final decision from NICE came on the 16th of January, which means that by the 16th of April, all sites should be able to prescribe vamorolone in clinical practice. And I'm embarrassed always to talk about this in front of a much better expert than me. But another important point that vamorolone is a corticosteroid, and therefore implicitly will be integrated into the standard of care as soon as it's approved, as an alternative to deflazacort or prednisone. And according to the corticosteroid guidance, because it's a corticosteroid, vamorolone should be discussed with every family that is diagnosed with Duchenne muscular dystrophy. What does NICE recommend in terms of use of vamorolone? First of all, the recommendation is for children age 4 and above. So at this time point, we are not able to prescribe vamorolone in younger children because there is not an indication. But in the NICE recommendation, there are no limitation in terms of age of the boy, in terms of upper age, so the older boys can still receive vamorolone, and there is no limitation in restriction in terms of whether the boy is still able to walk or unable to walk. And there are not stopping criteria, so all the decisions are based on a clinical assessment, and there are no NICE recommendations for this regard. I also want to emphasize that in the NICE recommendation, the dose is 6 milligrams per kilo per day on a daily regimen. This is important because we have, in Duchenne muscular dystrophy, we have used corticosteroid for many, many years, and as you probably all know, there are different corticosteroid regimens, different doses that are used. And we try, with this corticosteroid guidance, to try to avoid this discrepancy and diversity in how we prescribe corticosteroid, including vamorolone. And the recommendation is based on 6 milligrams per kilo per day because that's the dose that has been shown to be associated with the better efficacy. There are evidences that 2 milligrams per kilo per day, which were tested in clinical trial, is not as effective as 6 milligrams. However, in a sense, similar to prednisone or deflazacort, where we have an upper dose. So the standard of care do not recommend high doses higher than 30 milligrams per kilo 30 milligrams per day of prednisone or 36 milligrams per day of deflazacort. Similarly, there is an upper dose of vamorolone that is 240 milligrams per day, which means that every patient that weighs more than 40 kilograms will receive a maximum dose of 240 milligrams. And then there are some recommendations that if we need to adapt the dose based on the side effects, we should use a standardized approach to 4 milligrams per kilo per day and 2 milligrams per kilo per day. But I think that it's important to highlight the fact that it's a corticosteroid and is an option to deflazacort or prednisone. So we now have 3 options to discuss, but not one corticosteroid will fit all. And this is also highlighted in the NICE recommendation, where they clearly state that is a healthcare professional judgment in discussion with the family to understand what would be the best treatment and whether vamorolone is the best option for that particular patient. So what I showed this one already yesterday, slightly different, but what will help us in making that decision? Which factor do we need to take into account? And I think that there is, again, the family preferences, the child preferences, and some clinical evidence that can help us in making this decision. But probably there isn't really a right or wrong decision. It's something that even more now than before, we really need to discuss and weigh the pros and cons, and can be different from family to family, from patient to patient. It's easy to think that if we know that, as I mentioned, vamorolone seems to have a better profile in terms of height and potentially in terms of bone protection, but not necessarily on weight. So if the major concern is about weight, maybe switching from deflazacort to vamorolone might not be the best idea, or might not be the best interest. But if you have a very small boy for which is very upset because of the height, you might consider vamorolone. And there are several factors that will be part of that discussion. There are some considerations that will also need to be considered. For example, the fact that when we move from prednisone deflazacort to vamorolone, it's ideally to move to high doses of vamorolone for the risk of adrenal suppression. So this will need to be taken into account, that you might move from a low dose of prednisone deflazacort to a higher dose of vamorolone, and what is the potential side effects of this. Also, I want to remind everyone that we do not have evidences about what is the effect of switching from traditional corticosteroid to vamorolone after years and years of exposure. And these are data that will hopefully emerge with time, but at the moment will be very difficult for us as clinicians to advise you on this. So there is a lot that we don't know. Is the long-term effect? What is the impact on side effects that usually occur after longer exposure to what has been used so far in clinical trial? Again, what is the effect on older boys? What is the effect in adults? And this is not something that, therefore, we cannot prescribe vamorolone, but has to be based on a discussion and the knowledge that some answers are not ready. I just want to mention about what are we doing in order to implement vamorolone into clinical practice. And I just talked 2 minutes ago about there is probably a little bit of silence between January and April. And there is this big date of the 16th of April when magically everybody will be able to prescribe vamorolone, but so far we have been quite quiet. We have not been quiet. We have a little bit work in order to prepare the field, and not only the patient community, but also the clinician community, to be able to prescribe vamorolone. We need to remember that so far vamorolone has only been used in clinical trials, so it's also a limited number of clinicians are familiar with vamorolone. And for us it was important that all clinicians are able now to consult family with the same level of information about pro and cons of vamorolone versus others. And that is where we concentrate our energy over the last few months. So we have prepared the summary of evidence, as I mentioned, and we have done the webinar. We are trying, as I mentioned at the beginning, to harmonize care, and really this is an effort that is from all the community, clinician and patient community. We'll try, there is a lot of unknown about vamorolone. If we start to be inconsistent about how we use vamorolone in clinical practice, we will never have that answer. If someone starts to have intermittent regimen of vamorolone, someone starts of 3 milligrams and 1 milligram and 5 milligrams, in 5 years' time or in 20 years' time, we are still asking about which corticosteroid should we prescribe in Duchenne. And I think that it's important that we learn from our mistake that we have done so far with the classic corticosteroid and try to address this with a more scientific approach also in real life. But it's an effort that we all need to make. We have released the bone and endocrine management guidelines, and we are now working on the patient and family guidelines on corticosteroid, where we'll summarize the approach and what factors need to be considered in that choice. But we also try to contribute to generate more evidence about vamorolone, to be able to answer in a few times to the question that we now cannot answer. So some of the sites that took part in the original clinical trial with vamorolone are taking part in the Guardian clinical trial. That is for people who have received vamorolone in the original study are continuing to receive vamorolone under compassionate use. And this will help us to collect some evidence about what is the long-term efficacy and side effect profile of vamorolone. A small number, but it's still worth it. We are including the vamorolone in the North Star form. That is what we all complete in clinic in order to collect that evidence, have more information about the effect of vamorolone in a broader population, because we so far has only been tested in children aged 4 to 7, and in clinical practice these will obviously be expanded, so we'll learn about that. But we also learn about the effect of switching from classic corticosteroid to vamorolone, for which so far we do not have any clinical information. We are also part of, and this is really the endocrine and Jared Wong team, that is contributed to international initiative like Optimize to try to understand the effect on vamorolone on aspects, specifically endocrine aspects, the bone, the adrenal, the puberty, for which so far we do not have data. And finally, I think that it's important to share experience and maintain that discussion and learning. So we are discussing with the North Star whether we could have some context when we can discuss among clinicians complex cases and how do we make that decision. And working collaboratively with the patient community to learn from you. I now move on to a different molecule that is Givinostat. Givinostat has a different mechanism of action and is a little bit more complex and probably does not act on one effect only. So vamorolone is an anti-inflammatory, similar to corticosteroid, when Givinostat has a much more complex mechanism of action and acts on different aspects that are the consequence of the lack of dystrophin in skeletal muscle. So act as an anti-inflammatory, but as mentioned today by Jordi, also act as an antifibrotic and increase the ability of the muscles to generate new muscle cells. What we know so far about Givinostat comes from what we call is a phase 3 clinical trial that was run a couple of years ago and was tested in almost 180 boys. Of them, 118 boys received Givinostat and 60 boys received placebo. And they were treated for a period of 18 months with daily Givinostat. All boys were age 6 and above, but they were all able to walk at the time of treatment. And they needed to be on a stable dose of corticosteroid. So differently than vamorolone, Givinostat is something to add to the current corticosteroid treatment, whether it's vamorolone, prednisone, or the Deflazacort. So that is the data that we have about Givinostat. Again, is a very brief summary. I presented the data on the result of the study last year in this conference. So I here briefly summarize that. And what this clinical trial has shown that after 18 months of treatment, Givinostat was able to, what we say, slow down the disease progression, which means that was tested using common outcome measure, that is the North Star ambulatory assessment, or the time that the boys take to get up from the floor, or to run 10 meters, or to climb 4 steps. And consistently across all these measures of muscle strength and muscle function, the boys that were treated with Givinostat deteriorate less compared to the boys that received placebo. It is important for me to say that is not an improvement, but is slowing down the decline. But was very consistent across the different outcome measures. From a safety perspective, it was overall well tolerated. There are some side effects that we know that are relatively common, that is diarrhea, diarrhea, vomiting, reduced platelets, that is something in our blood that potentially increase our risk of bleeding or coagulate less, and can cause high triglyceride, that is a level of lipid in our blood. Some side effects are more common than others, and some occur at the beginning of the treatment and other a little bit later. But when we talk about the abnormality in terms of the potential risk of bleeding or the increase of lipid, was all in the trial detected on blood test, and there was no symptoms, so the boys were fit and well, reason for which the drug was overall considered well tolerated. But again, these are data from a limited study. We can say that 120 boys is a big number, but it's not a massive number, and were treated for up to 18 months. So again, there is still, as usual after a clinical trial, uncertainty about the long-term effect, the long-term side effects, and how does it really work on other muscles, such as the breathing muscles. We also know that Givinostat so far has only been tested, the results that are available are only related to young ambulant boys. There are currently ongoing clinical trials that are testing in other populations, but so far the data are unknown. But the program of Givinostat and DMD is not ended with the clinical trial or the MHRA approval, and currently there are 3 clinical trials with Givinostat. One is an open label extension study of the boys that took part in the original Givinostat study. There is a current clinical trial in young children aged 2 to 6, and there is an open study in non-ambulatory children, because they still need to be under 18. So we will have more evidence on Givinostat coming up in the upcoming years. But where do we start with Givinostat? So Givinostat has been approved by the MHRA in December 2024. And I just pointed out how many things happened just a week before Christmas. And is currently going through the NICE process. And as shown by Volker this morning, the result of the NICE consultation are expected at the end of the summer, so September 2025. And this is a very simple version, sorry, Fleur, I apologize for that. But you need to remember that as a clinician, neurologist, pediatric neurologist, we are not trained on regulatory, and everything that I know, I badly learned from Fleur, so thank you. But I think that I wanted to point out why. What is the difference between the MHRA approval and NICE? What is the difference between Givinostat and Vamorolone? Why are we talking about prescribing Vamorolone in clinical practice when all of you are struggling to receive Givinostat under the early access program? What is the difference between the two? The MHRA and NICE are two regulatory bodies, but it was already mentioned by Fleur. The MHRA is a regulatory agency that licenses medicines based on safety and effectiveness. So they just look at the data and say, is this drug safe? Is this drug effective? And if it's safe and effective, is a yes. End of the story. NICE is the authority that actually measures the cost effectiveness. So on the top of being safe and effective, they need to say is worth for money. And should this be reimbursed? And that makes a significant difference, okay? So Givinostat has only received the MHRA approval, so it's safe and effective, has received on a very broad population, anyone age 6 and above, ambulant and non-ambulant. Even we do not have evidence in non-ambulant population, but is considered that based on the fact that it works in ambulant, should also work in non-ambulant. And now NICE now is evaluating to say, but is cost effective? And they might come out with a different, I think, opinion about, yes, can be cost effective in this population, but not in this population. So the fact that has been approved by MHRA for everyone, it doesn't necessarily mean that will be implemented in everyone, right? Good. And I think that this summary that is taken from the NICE approval of Vamorolone really explain well the implication for this. Once a drug is approved by NICE, the commissioner has the obligation, in a way, to provide the required funding to deliver the drug in clinical practice. This only happens after the NICE approval. Before, with MHRA, there is no obligation to associate the delivery of the drug in clinical practice with funding. And is this one. And the aim of this reimbursement is to guarantee that there is no discrimination, there is an equality of access. But this is guaranteed after NICE approval. With the MHRA is each individual trust that need to decide whether they have funding and they want to dedicate the funding that they have to that specific program and not to another drug that can be cancer, can be hematology, rheumatology, whatever come in. Where do they want to invest the funding? And because it's a decision of each individual trust, one trust might say yes, and one trust might say no. And this inevitably creates discrepancy and inequality of access. But why are we talking about all this fuss? Because one advantage is that when we talk about MHRA approval, and the company are really supportive in is what we say is the early access program. In early access program, the company covered the cost of the drug, which is an important component. But by regulation, because the drug is not reimbursed, they cannot actually fund the delivery of the drug, because they otherwise are seen as a company that are encouraging the prescription of a drug that has not been NICE approved. So they are a little bit stuck in this. But on the other hand, the commissioner do not have the obligation to fund it. And in addition to the cost of the drug, there are other costs in the delivery of the drug that are quite important. Sometimes it's the storage. The Givinostat in particular is relatively easy because it does not need to be refrigerated, etc. But if a drug needs to be refrigerated, we need a space in the fridge or in the freezer in the hospital. They have the drug preparation that can be more or less complicated. And there is the drug shipment, because some of you live next to the clinic and they can come and collect the drug, others live far away. and how do I give you the drug. But there are also clinical costs, because obviously if I prescribe a new drug, means that they might have additional clinic visit, and they need the space to deliver this clinic, and they need the staff to deliver this clinic. That can be the clinician, the nurse, the physiotherapist. The visits usually are longer because I need to explain to you what I'm giving to you. There is additional blood tests maybe, and the lab has some cost related to this. And there are the safety monitoring, which means that is the coordination of the monitoring and make sure that there is a clinician that makes that safety decision. And this is the example of Givinostat. What does it mean in practice? Is, for example, because of the potential side effects on the platelet and the triglyceride, in terms of implementing, so to prescribe Givinostat, I need to make sure that it's safe. And what is the requirement? That every child that is prescribed with Givinostat has a blood test every 2 weeks for the first 2 months, and then a month 3, month 6, and then go into the standard of care of 6 months. But all these assessments are not currently in the standard of care. It is an addition to what we usually do. And obviously, there are other side effects for which, if anybody experiences them, I need to be able to address, and I need to be able to call the patient back and monitor for other side effects. So there are some additional activities. And there are also a lot of unknown and uncertainty when we introduce new drug in clinical practice. These are drugs that are less known. So there are some unknown, potentially considering about drug interaction. These are new drugs. How do they interact with all the drugs? How do they interact between them? So if I prescribe Vamorolone and Givinostat, does Vamorolone and Givinostat interact with the ACE inhibitors, eplerenone, beta blocker, and everything else? We don't know. And there is the possibility, we need to monitor and be careful that we do it safely. What is the effect of this new drug on other organs? We need to monitor it. What is the impact of taking this new drug, for example, in participation in clinical trial? And we want to make sure that the time that we prescribe, this is clear for everyone and all parties involved. And for example, another difference is that if a drug is approved by NICE, generally, and I think really generally, is more likely that will be allowed within clinical trial, not always. In early access program, is still considered an investigational drug, and therefore participation in clinical trial is not allowed. And it's similar to what actually I think that Emily opened the day yesterday, thinking about what are the implications. And it is sad, but it's the reality that all of these requests we want to improve care, we want more clinical trial, we want more new treatment. We have different neuromuscular conditions, and all of them are fortunately progressive in terms of care and in terms of clinical trial. But within the hospital and a lot of our services, there are also a lot of other conditions. And unfortunately, all of these follow on the same system that has not expanded to reflect this expansion in care, but is actually shrinking because the political situation. So it's difficult. We try our best, but it's difficult. But again, also for Givinostat, we are trying our best. And I think that what we are doing so far, we are really supporting the great effort of Duchenne UK in their call to have the early access program, I think, process and pathway improved. And this might result in a success of Givinostat, hopefully, or might be too late for Givinostat because hopefully will be approved by NICE. But it's something that we need to do because hopefully we will have new drug coming through the early access program, and we must be more prepared. There are 2 sites in the UK that has implemented already, managed to implement the early access program for Givinostat. But it's also nice to hear that actually all the clinical trial sites of the North Star has submitted an application and are trying. Some of them hopefully will be successful, maybe others no, but we are all trying. We are mapping the current barrier in implementing EAP, and this can be, again, useful for Givinostat or for the next drug going through the process. And we are trying, again, to harmonize care and planning the same approach that we have for Vamorolone for Givinostat to make sure that everybody is aware of what Givinostat is and how does it work. We are contributing to the generation of new evidences. As I mentioned, there are 2 clinical trials in young children and non-ambulatory children that are ongoing, and we are part of them. We have already ready to include the Givinostat in the North Star to allow us to collect the data in clinical practice. And we continue to deliver the long-term extension study with Givinostat to collect more evidence and consistent evidence on the long-term effect. So my take-home messages are really that new treatments are available. It is an exciting time. Are not a cure, are probably not even an improvement of motor function and strength, but slow down. And it's true that it's not enough, but it's a starting point. And for the patients that are facing Duchenne now, might be enough for now. But there are different implications, and we really need to work together as the patient community and the clinician community to have this true. And if we start to fight one against the other, will not be productive, but if we work together, I think that we'll get farther. There are a lot of unknown, and we need to address these unknown, and therefore there will be precaution, will be attention, and I think that nothing is more important now that collect data and learning that clinical trial help, but without the collection of consistent data in real world, we will not learn enough about the drug. And I finish. I know.
We're just getting some mics to the audience, so please put your hand up if you'd like to ask a question.
Hello, thank you for the presentation. I had a question on Givinostat. You mentioned that it's given in addition to corticosteroids, but would that mean the dosage of corticosteroids can be reduced or?
Sincere opinion, no. I know that the steroids are the bad guys. That corticosteroids are the bad guys, but are also the drug that has been shown to be effective. We also know that at least in young ambulatory boys, there is the recommended dose of steroid is 0.75 or 0.9 for the Flazacort, 6 milligram for Vamorolone, but there is an optimum dose where you have the maximum benefit. And we know that the lower doses have less efficacy. What we want to do is to make the boys decline slower. If you add Givinostat but you reduced corticosteroid, I'm not really sure that we'll reach that objective, but actually you will have the negative effect, and I'm not really sure how the two even balance to say at least I keep the best form. So for now, for the evidence that we have, I will still highly recommend to have the optimum dose of corticosteroid in addition to Givinostat.
Hi. My name's Kirsty and I have 2 sons with Duchenne. The question I'd like to ask is, if in a perfect world that you were able to prescribe both drugs right now, you obviously can't start them both together because we wouldn't know if there were side effects from either one. Which drug would you start first?
I don't think that there is one law for everyone. So it really depends of the circumstances. So there are some patients, some boys that might already be on a stable corticosteroid, they're managing well, they don't have major side effects, they're doing well. I do not see the priority to change to Vamorolone and I will start Givinostat. However, if someone has a lot of side effects, is still young, when I can still benefit on the potential advantage of Vamorolone in terms of height and on bone, I might prefer to say with Vamorolone. And sometimes, I know that sometimes we are really thinking about, okay, if I have both of them in my child, which one first? I think that 2 important messages. Maybe this situation will never happen, because the reality is that at the moment I cannot prescribe either, for example. Hopefully in a couple of weeks I can prescribe Vamorolone. It's luckily in Newcastle that I will be able to prescribe Givinostat in a couple of weeks. Hopefully a little bit longer, but I genuinely don't know. So sometimes it's also thinking that both of them are not life-saving drugs. So starting one or the other will not make a huge difference, or one before the other. And therefore do not have the anxiety to say which one do I choose first. Because at the end of the day, I don't think that will make a significant change. And I was also thinking about how do we implement, I was talking just before this talk, this drug in clinical practice. The reality is also that we have clinics, but a lot of you would be potentially eligible for Givinostat. So let's say that is tomorrow approved for everyone age 6 and above. And a lot of you will be eligible for Givinostat, and a lot of you will be potentially interested in considering Vamorolone. I cannot call you all in a week. So we'll need any way to be distributed by time, and maybe this is what will dictate what you start first.
Hi, thank you so much. One of my questions and anxieties was if you were to switch from prednisolone or to Flazacort to Vamorolone, is there a protocol for that can avoid adrenal suppression? Because, you know, at 11 o'clock every day I panic that I've forgotten to give it to him or my husband's forgotten to give it to him. So I can just see where this will go wrong in the household. Thank you.
Yeah, actually, so first of all, the recommendation is that if we switch from prednisone deflazacort to Vamorolone, we need to switch to 6 milligrams per kilo per day. And this is regardless the dose that the boy is receiving of deflazacort or prednisone. So even if they are on a suboptimal dose of deflazacort prednisone, 0.5, 0.6, like most of our boys, they will still need to move into the highest dose of Vamorolone, and this is to contain the adrenal, which has implication because potentially you can have a benefit in terms of strength because you give higher doses, but you can also have increased side effects, especially regarding weight, if you move from 0.5 to higher. But the reality is that we do not know that. We do not have data about the switching, and we cannot compare 0.75 of prednisone are equal than 6 milligrams of Vamorolone. We do not know that precise comparison. Once we move, there is a protocol that is designed in the endocrine guidelines about switching to Vamorolone. And the general approach is that if we can switch to 6 milligrams, we just need to inform family about what could be the potential sign of not an adrenal crisis, but is what to say is just that your adrenal gland is a little bit sleepy. So there are some boys reported anecdotally, in a sense, from the United States where they are receiving Vamorolone through clinical practice for a while, where the boys, when they switch, they have a few days where they have a period, and sometimes of a few days, some of months, when they feel weaker, they feel tired, and this potentially is an effect of the adrenal. So there is guideline about if they show these symptoms, how to treat them, and in general is you integrate with hydrocortisone. But will hopefully be also a leaflet for family to say exactly what you need to do, and for GP to prescribe that.
Thank you. Hello, sorry. If my son was to get Givinostat through the early access program, if the trust started to prescribe it, is there a possibility then that he could have it taken away if NICE then don't approve it for everybody, if they say that you have to be able to, stand, walk, etc.?
Is anyone from Italfarmaco here? No. I don't have a clear answer. So there is the potential risk, but I guess that Italfarmaco will be willing to continue to provide the drug. So potentially yes, but the pharmaceutical company can agree to continue to pay for the drug in order to continue treatment if you have been initiated with the treatment under an early access program. Obviously, this is also need to be agreed by the clinician, and then but in principle, I think that will be difficult that someone will have the heart to say no. But I cannot be guaranteed because it will depend on a single individual situation.
I just wanted to say yes. So the trusts, when we work with the trusts, they ask for letters to guarantee that. So that's a standard part of access programs.
Just a couple of, I guess, more logistical things. So my nephew, I think, wouldn't be able to get the EAP because he's ambulatory, but is standing from floor to standing is too slow, I believe. Is there any scope that the criteria, the EAP will change? And also on NICE approval, do we hear, I obviously have never followed NICE approval, do we hear anything kind of mid it, or is it very much we wait till September and then we get the judgment?
So I was hoping not to receive the first question. So first of all, the criteria that we clinically have defined for the current EAP is a very soft definition of ambulation. So as soon as the person is able to stand, even with support, so support means that you hold into something, we can still prescribe potentially Givinostat within an early access program. That is the criteria that has been defined. We are working through an early access program also for the non-ambulatory with the support of the company. It's difficult because we need to face the fact that there are no evidences so far, so Italfarmaco is really putting an effort in collecting evidence in the non-ambulatory. But if I face my trust and say I want Givinostat for everyone, the answer will be no. So is doing it step by step and working towards an effect that, but hopefully one day we'll be able to approve it, to allow those an EAP for the older one. And again, NICE can put the limit on the ambulation, but might not. So we also need to wait. For NICE, no, we need to wait for the final decision. They will not give any interim report. Yes, we need final decision. They do the decision. They might say that there is an interim decision, so a decision, but they want to have another meeting. We are hoping that NICE process, if you think about, I don't know how many you were involved in the Vamorolone, took a while to have the final decision from NICE. Hopefully, with Givinostat, we will not follow the same route and will be a quicker process, but might not be one decision. I might have a decision, then the appeal, and then the second one. This is general approach for NICE. And if I say anything wrong, please correct me.
The NICE process is what they aim to do is to have the single decision. So what they call the FAD, which is the final appraisal documents, they do aim to go straight for that. But you do most appraisals. Sorry. Oh, okay. So most appraisals do have at least one interim decision, which is called the ACD, which is the draft guidance, and that's published, and that is usually negative. So do not be surprised if you get a negative like in the middle, but does tend to be what happens. If it doesn't go straight to FAD, then that draft guidance is usually negative. But then you're moving into another meeting, or potentially more than one meeting, and then getting into that afterwards. And then the early access program will be sort of slightly different in terms of what they look at for who can attend it. And as Michela says, we will likely end up with different recommendations in different groups of boys with different evidence requirements to be collected moving forward. So Italfarmaco can correct me if I'm not right. That's just a general NICE process.
Thanks, Fleur. Have we got time for one more? Do you want to finish there? Where's the microphone?
In the meantime, the microphone. Sorry, can I just mention also that when we're thinking about switching, always remember that we have data from classic steroid to Vamorolone. We have data showing that if you switch from classic steroid to Vamorolone after 6 months, at least the height and the bone effect partially recover. And this partially, they don't completely go back to whether you have received Vamorolone from the beginning, but partially recover. But we do not know what happened after 5, 10 years of exposure to corticosteroid, and probably part of it depends on age. And for example, how much space of growth do you still have? So, sorry.
You've kind of maybe, half answered my question. It's about Vamorolone. If you've been on the traditional corticosteroid for a number of years and then you want to switch to Vamorolone and then your height improves, do you think there's actually might be a negative impact to, if your muscles are stretching sort of too much, that there might end up being a negative consequence to that decision?
The honest answer is we do not know. We have always, and there are some evidence actually, we always talk about it actually, for boys to remain small is a good thing. for different reasons. Is the stretch of the muscle. If you think in general, tall people are less coordinated than small people. And actually remaining small might be helpful for the muscle function and the muscle strength. That is what we know based on year of experience with classic corticosteroid. With vamorolone, it's true that for the first time we see children that follow the normal growth pattern. And we never have, we see tall Duchenne on steroid, which is the first time. So I can tell you that up to consistently 1 year, but up to 30 months, we do not see this significant difference between the one that are on vamorolone and are tall compared to the one that are small on traditional corticosteroid. But it's true that longer term, we might see that difference, and it's something that we need to carefully monitor.
I think actually there's a lot of interest in having our expert here answering these questions, so we'll take a few more if there are more questions that want to be asked.
Hi, can you hear me? Sorry, I need to give a bit of context, so I apologize for the lengthy question. So my son was on the vamorolone trial when he was 4. He was on it for 4 years. Then we had to stop and switch to deflazacort to take part in another trial, which we are currently on. He's in the extension part of the trial, and it will hopefully become open label in August. My question is pertaining to vamorolone and Givinostat. I'm very confused. What is your advice? Should I switch to vamorolone, or am I well within my rights to ask to stop deflazacort and switch to vamorolone, and then also ask for Givinostat at the same time? And who will approve that, or who should I go to?
So first of all, I will highly recommend to discuss with the PI of the clinical trial, because there will not be one role for every clinical trial. So in general, clinical trials are opening to vamorolone for 2 reasons. First of all, is a corticosteroid. So at the end of the day, when they allow corticosteroid, they allow also vamorolone. And obviously it's an approved drug and is a reimbursed drug, so it's difficult to say no to something that is implemented in standard of care. But quite often, there are some rules on that. For example, in order to take part in a clinical trial, you need to be on a stable corticosteroid for some trials say 3 months and some others say 6 months. So you need to, if you switch to vamorolone, you need to be on a stable vamorolone for the 3 months, 6 months before taking part in a clinical trial. Once you are in a clinical trial, usually, but it's not, I mean, it's really dependent on trial by trial, but usually in the first phase of the study, when they want to understand does the drug work or not, they will not allow to change corticosteroid, and therefore they will not allow to start vamorolone. But they might open to vamorolone in long-term extension monitoring. But it really depends trial by trial, so please discuss it with the PI.
But what if I have a very compelling reason for it? For example,
the point is not the compelling, is in which phase of the study. You need to remember that if you are in a clinical trial, you can always withdraw from the study and switch to whatever you want. But I always, and I'm very strong on that, because we do clinical trial, and you all know better than me how much commitment we put in a clinical trial. And I know that is very hard, but the failure of a clinical trial is that if after 2 years, 1 year, 2 years, 3 years, sometimes 6 years of clinical trial, I arrive at the end and say, I don't know if this drug works or not, because someone started Givinostat, someone started vamorolone, and I don't know. So the robustness of the data during the safety efficacy is really important. If you feel that for your boys, the most important thing is to vamorolone or Givinostat, you can always withdraw from the study, and it's okay. It's a trial, it's not a drug that you know that works, so it's okay. But discuss, because again, I know that, for example, for some study, I'm able to switch to vamorolone with no concern. Givinostat is different, because Givinostat is approved by the MHRA, but is not approved by NICE yet. So for now, is considered a investigational drug. So most of the clinical trial, but again, discussed with the PI, study by study, will not allow boys to start Givinostat. And obviously, it's also in addition to corticosteroid, so might be a little bit more problematic. Sorry, long answer.
Okay, we'll take one last one if we can.
Hi. As a parent, if I given an opportunity to choose between two drugs, either Givinostat or Translarna, which one I should go for? I mean, which one is more efficient?
So what are the options?
Translarna and Givinostat.
Let's say, one does not necessarily exclude the other. So for the approval system, you can take Translarna and Givinostat at the same time, obviously with the knowledge that there is no evidences, or we don't have any data on the combination of the two. So the two might interact, and therefore the monitoring in terms of safety has to be put in place, but you might not be in the position to choose one or the other. I think that there are two different drugs. So Translarna, as you know, has been around for a long, long time. It's specific for a patient with a stop codon mutation, so it's not available for everyone. The clinical trial has never failed to show the efficacy of Translarna. But there are real-world data long-term that might suggest that actually in the long term is still beneficial. Givinostat, we are exactly in the opposite situation, where you have a short period of time and they reach the statistical significance. So if you want to choose one or the other, is really a little bit of what you think that is in the best interest.